Welcome back, everyone, to part 6 of our ongoing masterclass series. Today, we are putting on our clinical detective hats and diving deep into Sepsis-2. Now, if you're a medical coder, a CDI specialist, or an auditor, you already know that sepsis is notoriously one of the absolute hardest conditions to accurately capture and to defend. But getting it right, it's not just about hospital reimbursement. It is about painting an accurate clinical picture of how sick that patient truly is. So in this explainer, we're going to break down the exact clinical parameters and the diagnostic mapping criteria that you absolutely need to master.
Okay, let's look at our agenda for today. First, we're decoding Sepsis-2 parameters. Second, we'll look at the 5 clinical categories. Third, we map the diagnostic hierarchy. And finally, number 4, we'll cover real-world CDI chart audit takeaways.
All right, let's jump right into Section 1, Decoding Sepsis-2 Parameters.
You know the feeling, right? You open a patient's medical record and bam, you are hit with a literal wall of scattered clinical clues. You've got fluctuating vitals, crazy lab results, endless nursing notes. It's a lot of noise. But our job is to cut through that noise. We funnel all that raw data into a rock-solid, completely defendable diagnosis. So the big question is, how do we objectively map Sepsis-2? How do we take that chaotic sea of data and translate it into compliant medical coding? Well, it all starts with understanding the foundation of the condition itself.
So, before we even look at the raw numbers, we've got to grasp this core premise. Back in 2001, the Surviving Sepsis campaign defined Sepsis-2 as a deleterious host response to an infection. I want you to focus on that word deleterious. It means incredibly harmful, destructive. The body isn't just fighting a localized infection anymore. The systemic response has gone rogue and is actively destroying its own tissues and organs. That right there is our guiding principle. When we're auditing a chart, we are literally hunting for evidence of that destruction.
Moving right along to Section 2, the 5 clinical categories. To organize all that chart chaos we just talked about, we sort those scattered clues into 5 distinct, highly objective buckets. These are the 5 foundational pillars we use to build our clinical funnel. We've got general parameters, inflammatory parameters, hemodynamic parameters, organ dysfunction parameters, and finally, tissue perfusion parameters. You've got to memorize these 5. They're the absolute scaffolding of any compliant Sepsis-2 chart review. Let's break down exactly what lives inside each of these buckets.
Starting with your baseline clues, under general parameters, we are looking for signs of systemic stress, spotting a fever over 38 degrees Celsius, or maybe hypothermia below 36, a heart rate spiking over 90, or a respiratory rate over 20. We're also checking for an altered mental status, where that Glasgow Coma Scale drops below 15, any significant positive fluid balance, or, and this is a big one, unexplained hyperglycemia in a non-diabetic patient. Then, on the inflammatory side, we hit the labs. Is the white blood cell count soaring past 12,000, or is it crashing below 4,000? Are the CRP and procalcitonin elevated by more than 2 standard deviations? When you see these markers, the body is basically waving a giant red flag that a severe inflammatory cascade has started. As a CDI pro, you want to hunt through those EMR lab tabs specifically for these objective spikes and crashes.
Now, as we move into the hemodynamic and organ dysfunction parameters, the severity ramps up fast. For hemodynamics, we are laser-focused on the mean arterial pressure, the MAP. If that drops below 70 millimeters of mercury, organs simply can't get enough blood. They literally start to starve. And that brings us to organ dysfunction. These are your critical gotcha metrics as an auditor. You've got to scan for arterial hypoxemia, like a PFP ratio under 300. Watch those kidneys. Is urine output dropping below 0.5 ml per kilo per hour? Or maybe an acute creatinine jump of more than 0.5 from their baseline? Check the liver and blood panels too. Bilirubin over 4 and INR greater than 1.5, or platelets just plummeting below 100,000. Keep in mind, these aren't just random lab values. They are undeniable, objective proof that the patient's organs are shutting down.
Finally, we check the tissue perfusion parameters. This category represents a critical lack of blood flow all the way down to the microscopic cellular level. The real hallmark here, a serum lactate level climbing above 3 to 4 millimoles per liter. Remember, when cells are forced to generate energy without enough oxygen, they produce excess of lactic acid. Visually at the bedside, the provider might note mottled skin or a delayed capillary refill time of more than 3 seconds. Once you hit this category, that patient is in a profoundly dangerous state.
Okay, let's jump into Section 3, Diagnostic Mapping Hierarchy. So we've gathered all our raw data from those 5 buckets, and now we use our clinical funnel to establish the diagnostic hierarchy. But look, before you build a house, you need a foundation, right?
The absolute base requirement for Sepsis-2 is that the medical record must have evidence of physician documentation of a documented or suspected source of infection, whether it's a UTI, pneumonia, a surgical site infection. If you don't have that documented or suspected source explicitly written in the chart, the rest of the Sepsis-2 funnel is completely locked. You can't even begin. It is the mandatory trigger.
And this lays out the stacking concept of Sepsis-2 perfectly. Notice how the clinical severity just builds, step by step. Step 1 is your standard sepsis. You need that documented infection we just mentioned, plus at least one criterion from the general, inflammatory, and hemodynamic parameters. Then, Step 2 elevates to severe sepsis without shock. Here, you take everything from Step 1 and you stack on at least one acute organ dysfunction parameter, like that elevated creatinine we talked about. Finally, Step 3 is severe sepsis with septic shock. You take all the parameters of severe sepsis and you add a tissue perfusion parameter, like a dangerously high serum lactate. Each tier relentlessly builds upon the last. Which brings us to our final part, Section 4, CDI Chart Audit Takeaways.
All right, detail-oriented auditors, listen up, because this is your golden rule. We just spent all this time mastering the clinical criteria, but the ICD-10 official coding guidelines, specifically Section IA-19, makes something very clear. It states, the assignment of a diagnosis code is based on the provider's diagnostic statement that the condition exists. It explicitly says that code assignment is not based on clinical criteria. So what does that actually mean for you on a Tuesday morning reviewing a chart? It means you can have a chart absolutely screaming with high lactate, a crashing map, a massive fever, but if the physician does not explicitly write the word sepsis in the notes, you cannot code it. Clinical indicators alone are never, ever enough.
So what's your actual chart review strategy? First, use those 5 parameter categories to objectively identify the clinical reality of what's happening to the patient. Second, you hunt for that explicit provider diagnostic statement. And third, you bridge the gap. If you see the objective criteria for severe sepsis stacked up in the labs, but the provider only wrote down a localized infection, that is a massive missed opportunity. You have to query the provider. Now I know, providers just love our queries, getting of course, but a joint effort between the physician and the coder is absolutely essential here. You are the safety net making sure the documentation actually matches the true severity of the illness.
So, we've officially mastered Sepsis-2. But what happens when these rigid criteria fail to accurately capture the sickest patients? That question completely changed the medical landscape. Stay tuned for Part 7, where we explore the Sepsis-3 revolution, the 2016 consensus definition, dysregulated host response, and the new paradigm. Until then, keep learning and keep leveling up. This is Decode Healthcare with Harshal.